In this lecture, we'll be discussing about bacterial corneal ulcer. Now, the definition of a corneal ulcer. Now, corneal ulcer may be defined as a discontinuation in the normal epithelial surface of the cornea, and it is associated with necrosis of the surrounding corneal tissue. So, any discontinuation in the normal epithelial surface of the cornea is known as a corneal ulcer. Now, let us look into the etiology. Now, two factors required for the production of purulent corneal ulcer are: number one, damage to the corneal epithelium, and number two, infection of the eroded area. Now, damage to the corneal epithelium may be due to corneal abrasion, example due to a foreign body, epithelial drying, necrosis of the epithelium, or epithelial damage. So this is what causes damage to the corneal epithelium. The second is infection of the eroded area. Now, most of the bacterial corneal ulcer arises from an exogenous source like a conjunctival sac, like from the conjunctival sac as in acute conjunctivitis, or from lacrimal sac as in dacrocystitis, or from an infected foreign body. Okay, so the two factors required for the production of purulent corneal ulcer are damage to corneal epithelium and the infection of the eroded area. Now, some common bacteria. We'll be discussing bacterial corneal ulcer in this video. So the common bacteria associated with corneal ulcerations, they include Staphylococci, which is the most common cause in general. So Staphylococcus aureus. The second is Streptococcus pneumonia. The third is Pseudomonas. Now, this is the most common cause of corneal ulcers in lens wearers. And finally, Enterobacteriaceae. So these are some of the common bacteria. Remember, Staphylococcus aureus is the most common cause, and in lens wearers, the most common cause is Pseudomonas. Now, the pathogens that can invade an intact epithelium and produce ulceration are Neisseria gonorrhoeae, Corynebacterium diphtheria, and Neisseria meningitidis. Okay, so remember, the two etiological factors required is damage to the corneal epithelium and infection of the eroded area. The most commonly common bacteria associated with ulcers are Staph aureus, and that in lens wearers are Pseudomonas. And the bacteria that can invade an intact epithelium, they are the Neisseria gonorrhoeae, Corynebacterium diphtheria, and Neisseria meningitidis. Now, let us move on to the pathogenesis of a corneal ulcer. Now, once the remember, damage to the corneal epithelium is a prerequisite for formation of corneal ulcer, and however, it is not required if the infection is by Neisseria gonorrhoeae, Corynebacterium, and diphtheria. Okay, so that was the revision. Coming back, pathogenesis. Now, once the damaged corneal epithelium is invaded by pathogens, the sequence of pathological changes can be described under the following four stages. First is the stage of progressive infiltration, then is the stage of active ulceration, then the stage of regression, and finally the stage of cicatrization. Okay, so again, stage of progressive infiltration, active ulceration, regression, and cicatrization. The first stage is the stage of progressive infiltration. Now, there is infiltration by the inflammatory cells like neutrophils and lymphocytes. The second is the stage of active ulceration. Now, ulceration, it occurs due to the necrosis and slowing off of the epithelium, Bowman's membrane, and the stroma of the cornea. Okay, and because of this, there occurs hyperemia of the circumcorneal vessels, vascular congestion of the iris and ciliary body, and hypopyon formation. Okay, so this is the stage of active ulceration. That is, necrosis of the cornea occurs, and it results in hyperemia of the circumcorneal vessels, vascular congestion of the iris and the ciliary body, and hypopyon formation. Now, remember, hypopyon, it is the formation of pus in the anterior chamber. Now, the stage of regression. Now, it is induced by the natural host defense mechanisms. That is, the healing process begins. So, beginning of the healing process is the stage of regression. Now, stage of cicatrization. In this stage, the healing continues by progressive epithelialization, which forms a permanent covering known as a corneal opacity. So, this is the stage of cicatrization. Now, the degree of scarring from healing, it varies, and hence the corneal opacities are of different types. Now, the different types are nebula, macula, leucoma, adherent leucoma, corneal facet, keratosia, and anterior staphyloma. Okay, so remember, the corneal ulcer, it heals with the formation of scar, and hence a corneal opacities are formed. Now, the different types of corneal opacities are nebula, macula, leucoma, adherent leucoma, corneal facet, keratosia, and anterior staphyloma. So this is a commonly asked question in your vivas: what are the different types of corneal opacities? So this is your answer. So we've discussed the Pathogenesis. Now, depending upon the prevalent circumstance, the course of the corneal ulcer, it may take one of the following three forms. Okay, the ulcer becomes localized and healed. The ulcer may penetrate deep and it leads to corneal perforation, and finally the ulcer may spread fast to involve the entire cornea. Okay, so again, we can describe the pathogenesis of corneal ulcer under four headings. The first is stage of active infiltration by inflammatory cells like neutrophils and lymphocytes. The stage of progressive infiltration. The second is the stage of active ulcerization, where the necrosis and slowing off of the various layers of the cornea occurs. The third is the stage of regression, where the healing begins, and once the healing continues, it is known as stage of cicatrization. And remember the different types of corneal opacities. That is, the cornea heals with scar formation, and the formation of scar leads to the formation of corneal opacities, and the various types of opacities are nebula, macula, leucoma, adherent leucoma, corneal facet, keratosis, and anterior staphyloma. So this is the pathogenesis. Now coming to the clinical features. Now again, we have symptoms and signs. Now the symptoms include pain and redness, watering from the eye, photophobia, and blurred vision. So these are the common symptoms: pain and redness, watering from the eye, photophobia, blurred vision due to corneal haze. So these are the symptoms. Now the signs. Now there is swelling of the lids, blepharospasm may be present. There may be conjunctival congestion or circumcorneal congestion. Now most commonly it is circumcorneal congestion. Now a favorite question in your vivas is how can you differentiate between conjunctival congestion and circumcorneal congestion? Now let us look at the differences. Now the site. Conjunctival congestion, it is more marked at the fornix, whereas ciliary congestion or circumcorneal congestion, it is more marked around the limbus. Okay, the second is the color, because conjunctival congestion, it is bright red in color, whereas ciliary congestion, it is dull red or purple in color. Now the arrangement of vessels, these are superficial and branching, whereas circumcorneal congestion, it is deep and radiating from the limbus. Okay, then these are the main important differences. Then other differences are on moving the conjunctiva, the congested vessels also move in conjunctival congestion, whereas they do not move in ciliary congestion. Then mechanical squeezing out the blood vessels, the vessels fill slowly from fornix towards limbus, whereas in ciliary congestion they rapidly fill from the limbus to the fornix. The next difference is blanching. Now in conjunctival congestion, the vessels immediately blanch, whereas they do not in circumcorneal congestion. And the last difference is that conjunctival congestion is commonly seen in acute conjunctivitis, whereas ciliary congestion, it is seen in iridocyclitis and keratitis. Okay, so this is an important question in your viva. So remember, how do you differentiate between conjunctival congestion and circumcorneal congestion? First is the site. It is more marked in the fornix, whereas the ciliary congestion is more seen around the limbus. The color is bright red, whereas in conjunctival congestion, whereas it is purple or dull red in ciliary congestion. Then the arrangement of the vessels is superficial and branching, whereas it is radiating from the limbus in ciliary congestion. Then on mechanically squeezing out the vessels fill from fornix to limbus, whereas in ciliary congestion it fills rapidly from the limbus to the fornix. Then another difference is that conjunctival congestion is commonly seen in acute conjunctivitis, whereas ciliary congestion, it is seen in acute iridocyclitis and keratitis. So remember, in bacterial keratitis, circumcorneal congestion is seen. Okay, so the signs we've discussed till now are swelling of the lids, blepharospasm, and circumcorneal congestion. The fourth is the corneal ulcer. Now the corneal ulcer, it is a bacterial corneal ulcer. It is usually oval or irregular shaped and yellowish white ulcer. The margins are swollen and overhanging, and the floor of the ulcer is covered by necrotic material. So on examination, the lids are swollen, blepharospasm may be present, the circumcorneal congestion is seen, and a corneal ulcer is seen. Now in your case discussion, that is when you are writing a case for corneal ulcer, you have to describe in detail the corneal ulcer, how the margins are, how the area, like example is 3 into 4 millimeter square area of corneal ulcer, whether it is surrounded by a corneal opacity or not, then its distance from the limbus in millimeters. All of this should be included when you're describing the corneal ulcer. Now, certain points to note. Now, if the corneal ulcer, it is oval in shape, yellowish white, densely opaque ulcer, and it is surrounded by a clear cornea, then this kind of ulcer is most likely produced by Staph aureus or Streptococcus pneumonia. Okay, so you can see in this diagram an oval shaped yellowish white ulcer which is surrounded by a clear cornea, then it is most likely due to Staph aureus or Streptococcus pneumonia. Now, if it is an irregular shaped sharp ulcer with thick greenish mucopurulent exudate, as you can see in this diagram here, an irregular shaped sharp ulcer with greenish thick mucopurulent exudate, and the surrounding cornea is semi-opaque with ground glass appearance, then it is most likely due to Pseudomonas infection. Now, if the ulcer it is ring shaped shallow ulcer with grayish white suppuration and there is diffuse stromal appearance, then it is most likely due to gram-negative infections such as E. coli. Okay, so this is the various types of ulcers depending on the source of infection. So this is about the corneal ulcer. The next sign is the anterior chamber. Now, in the anterior chamber, the hypopyon may or may not be present. Okay, then the iris is slightly muddy in color. Now, the pupil it is small. Now, because the toxin induced ciliary spasm, toxins produced by the infection. The eighth sign is that the intraocular pressure may be raised, and this type of this may lead to inflammatory glaucoma. So again, the signs: the lid swelling lid swelling is usually seen. Blepharospasm may or may not be present. Then the circumcorneal congestion is seen. Remember the differences between conjunctival congestion and circumcorneal congestion. Then we discussed the corneal ulcer. Now, depending on the corneal ulcer, we described the various source of infection. Now, if it is oval in shape and the surrounding cornea is clear, then it may be due to Staph aureus or Streptococcus. Now, if it is irregular in shape with greenish thick mucopurulent exudate, then and the surrounding cornea is semi-opaque with ground glass appearance, it is due to Pseudomonas infection. And if it is a ring shaped shallow ulcer with diffuse stromal opalescence, then it is most likely due to a gram-negative infection. Then the other signs are the anterior chamber. In the anterior chamber, hypopyon may or may not be present. Then the iris, because of infection, it is slightly muddy in color. The pupil is small because of constriction induced by toxins, and the intraocular pressure may or may be raised, and this can lead to inflammatory glaucoma. So these are the symptoms and signs of bacterial ulcer. Now note the term hypopyon corneal ulcer. It is a term reserved for characteristic ulcer produced by Pseudomonas infection, and such an ulcer is known as Ulcus serpens, as you can see in this diagram. Okay, hypopyon corneal ulcer with the typical presentation of the corneal ulcer in Pseudomonas infection, that is irregularly shaped, with thick greenish mucopurulent exudate. So this is the hypopyon corneal ulcer. Now, corneal ulcer with hypopyon, this term is reserved for infections caused by Staphylococcus, Streptococcus and Gonococcus. So again, the clinical features, they include symptoms and signs. The symptoms include pain and redness, watering from the eye, photophobia and blurred vision due to the corneal opacities. The signs: the swelling of the lids, blepharospasm, circumcorneal congestion, and remember the differences between the conjunctival congestion and circumcorneal congestion. Then the fourth is the corneal ulcer, which may be seen. The fifth is the anterior chamber, hypopyon may or may not be present, iris is muddy in color, pupil is constricted, and the intraocular pressure may be raised. And hypopyon with corneal ulcer is the term reserved for characteristic ulcer produced by Pseudomonas, whereas corneal ulcer with hypopyon is usually used for Staphylococcus, Streptococcus and Gonococci. Now remember the different types of corneal ulcer, that is, if it is oval, yellowish white, densely opaque with surrounding clear cornea, it is due to Staph aureus or Streptococcus pneumonia. And if it is an irregular shaped ulcer with thick greenish mucopurulent exudate and the surrounding cornea shows ground glass appearance, it is most likely due to Pseudomonas infection. And finally, ring-shaped shallow ulcer with diffuse stromal opalescence, then this is due to E. coli, that is gram-negative infection. Now let us move on and discuss the complications of corneal ulcer. Now the complications, these include, the first is the corneal scarring. It is the end result of a healed corneal ulcer and it can lead to permanent visual impairment. Okay, corneal scarring leading to corneal opacities, and we will discuss the different types of opacities like nebula, macular glaucoma, adrenal etc. The second is secondary glaucoma. Now fibrinous exudates can block the angle of anterior chamber and this results in inflammatory glaucoma. So the first is corneal scarring leading to defective vision. Second is secondary glaucoma, that is inflammatory glaucoma. The third is toxic iridocyclitis. Now the toxins produced by the bacteria and due to the inflammatory process, these may get absorbed by the iris and ciliary body and it can lead to toxic iridocyclitis. Now the fourth is descematocele. Now ulcers caused by virulent organisms, they extend rapidly up to the descematous membrane. But due to but the descematous membrane, it is the most thickest part, most resistant part of the cornea. Now but due to the effect of intraocular pressure, it herniates as a transparent vesicle and this transparent vesicle is known as descematocele or keratocele. So what happens is we have a corneal ulcer here. Okay, now it has extended because of the virulence of the high virulence of the organism. It has extended up to the descematous membrane because the descematous membrane is the most resistant part of the cornea. What happens is because of the intraocular pressure, it protrudes out, and this protrusion out, that is the transparent vesicle that herniates, is known as descematocele, and this is a sign of impending perforation. That is, this descematocele is prone for perforation. So this here represents the descematocele. So till now we've discussed the complications before perforation. So these include corneal scarring, secondary glaucoma, toxic iridocyclitis and descematocele. Now perforation of the corneal ulcer. Now because of sudden strain, that is due to a cough or a sneeze, the descematocele may convert the impending the sudden strain may convert the impending perforation into an actual perforation. Okay, so here what happens is because of a sudden strain, this ruptures and a perforation can occur. Now the sequelae of perforation, it includes prolapse of the iris. Now once the descematocele breaks, the intraocular the aqueous humor, the fluid comes out, and because of this the prolapse of the iris takes place. The first is prolapse of the iris. Along with it, the subluxation of and anterior dislocation of the lens, and a corneal fistula can form, that is an opening in the cornea. A corneal fistula may form. Then there can be anterior capsular cataract when the lens comes in contact with the ulcer. Purulent uveitis, endophthalmitis, panophthalmitis, and intraocular hemorrhage may occur. Okay, so remember, so these are the complications. So remember, we have complications before perforation and after perforation. Before perforation, the complications are corneal scarring, that is corneal opacities, and this can lead to defective vision. The second is secondary glaucoma, that is inflammatory glaucoma. The third is toxic iridocyclitis due to absorption of the toxins by the iris and ciliary body. The fourth is the descematocele, that is high virulence of the organism may cause ulceration of the cornea up to the descematous membrane, and because of the intraocular pressure, the descematous membrane, it protrudes out as a transparent vesicle, and this is known as descematocele or keratocele. Now due to some sudden strain, like due to coughing or sneezing, the descematocele may rupture, and this leads to the leakage of the intraocular fluid, that is aqueous humor. This can lead to prolapse of the iris, subluxation of the lens. The corneal fistula can be formed. If the lens comes in contact with the ulcer, anterior capsular cataract is seen. Purulent uveitis, endophthalmitis, panophthalmitis can occur, and intraocular hemorrhage may also occur. So you can see in this diagram the rupture of the corneal, the perforation of the descematocele along with the prolapse of the iris. So these are the complications. So what all have we discussed? We discussed the definition of corneal ulcer, the etiology, the pathogenesis, the 4 stages, the signs and symptoms, then and now we've discussed the complications. Now coming to the management. Now the management, it involves clinical evaluation, general examination and ocular examination, laboratory investigations and treatment. Okay, now clinical evaluation, it includes general examination and ocular examination. Now the laboratory investigations, the materials for microbial examination is obtained by scraping the base and margins of the corneal ulcer under local anesthesia using a modified Kimura spatula. Okay, the corneal scrapings obtained is used for the following investigations, that is gram and gemsa staining, culture on blood agar medium, then 10% KOH webbed preparation, culture on SD agar medium, and calcifluor white or CFW stain preparation. All of this is to find the source of infection. So for lab investigations, we take the sample of corneal scrapings. Next is the treatment. Now the treatment can be using topical antibiotics, systemic antibiotics, adjunctive therapy. And the topical antibiotics, it forms the mainstay of treatment. Now the initial therapy, that is before the results of the culture and sensitivity, the treatment should begin with combination therapy. Now the usual combination therapy, it includes 5% fortified cefazolin and 1.3% fortified tobramycin, or it can include 5% fortified vancomycin and fluoroquinolone eye drops, such as 0.3% ciprofloxacin, 0.3% ofloxacin and 0.5% moxifloxacin. So again, the topical antibiotics before the initial therapy, it is done by fortified cefazolin and 5% fortified cefazolin and 1.3% fortified tobramycin, or 5% fortified vancomycin and fluoroquinolone eye drops such as ciprofloxacin, ofloxacin and moxifloxacin. Okay, so this is important, the topical antibiotics used in bacterial keratitis. Now the chosen drugs, it should be instilled 4 to 6 hourly until the healing occurs. Now the systemic antibiotics, they are not usually required, but cephalosporin, aminoglycosides, ciprofloxacin may be given in fulminating cases. Now the adjunctive therapy, it involves cycloplegic drugs such as to reduce the pain. Now these include 1% atropine or 2% homatropine, systemic analgesics and anti-inflammatory drugs such as paracetamol or ibuprofen, and vitamins A, B complex and C to promote healing. Now for non-healing ulcers, the cause should be identified and removed. The causes may be increased intraocular pressure, in which if that is the case, then lowering of the intraocular pressure must be done. Misdirected cilia, diabetes mellitus, anemia, malnutrition, etc. are all causes for non-healing ulcers. Now treatment of an impending perforation. Okay, so the patient is asked not to take any strain, like to avoid sneezing, coughing, etc. Pressure bandage for external support can be given. Lowering of the intraocular pressure, tissue adhesive glue such as cyanoacrylate, conjunctival flap can be used to cover and support the weakened cornea, amniotic membrane transplantation, bandage soft contact lens, and penetrating therapeutic keratoplasty can be done. So again, the management, we've discussed 3 modalities, 3 headings. The first is the general examination, that is the clinical evaluation, which includes general examination and ocular examination. Then we discuss the laboratory investigations, where the sample taken is the corneal scrapings, and it is subjected to a variety of microbiological tests to know the source of the infection. So these include gram and gemsa staining, culture on blood agar, 10% KOH wet preparation, SD agar, and CFW stain preparation. Then the treatment, the most common mainstay treatment is the use of topical antibiotics. Now remember, the topical antibiotics are 5% fortified cefazolin and 1.3% fortified tobramycin, or 5% fortified vancomycin along with fluoroquinolone eye drops. Examples are ciprofloxacin 0.3%, ofloxacin 0.3%, and 0.5% moxifloxacin. Now these drugs are given 4 to 6 hourly until healing occurs. Systemic antibiotics may be given, and adjunctive therapy includes cycloplegic drugs to reduce pain, systemic analgesics, and vitamins. So this is the adjunctive therapy. For non-healing ulcers, the cause should be understood, should be identified and treated. And treatment of the impending perforation is basically to support the descematocele. So this, the most important is to reduce the strain, to prevent strain. Then intraocular pressure lowering can be done. Then the rest techniques to support the descematocele. This can be due to pressure bandage, tissue adhesive glue, conjunctival flap, amniotic membrane, bandage, soft contact lens, and penetrating therapeutic keratoplasty. So with this, we've completed our discussion on corneal ulcer, bacterial corneal ulcer. We've discussed the definition of corneal ulcer, that is a discontinuation in the epithelial lining of the cornea. Then we discussed the etiology, that is damage to the cornea along with an infection is the prerequisite for corneal ulcer. We've discussed the 3 organisms that can invade a intact epithelium, that is Neisseria gonorrhea, Cyanobacterium diphtheria, and Corynebacterium diphtheria, and Neisseria meningitidis. The most common cause of bacterial ulcer is Staph aureus, whereas in lens virus it is Pseudomonas. This is the etiology. Then in pathogenesis we discuss the 4 stages: the stage of progressive infiltration, active ulcerization, regression, and finally cicatrization. Then we discussed the clinical signs and symptoms. The sign is usually pain and redness, watering from the eye, photophobia, defective vision. The signs we discussed are swelling of the eyelid, blepharospasm, then circumcorneal congestion, and along with this we discussed the difference between circumcorneal congestion and conjunctival congestion. Then we discussed the corneal ulcer. If it is an oval shaped yellowish white with clear cornea, it is due to Staph aureus or Streptococcus, whereas if it is irregular in shape with thick greenish mucopurulent and surrounding cornea shows ground glass appearance, then it is due to Pseudomonas. And if it's ring shaped with diffuse corneal opacity, it is due to E. coli. Then we discuss anterior chamber hypopion may be present or may not be present. Remember, hypopion with corneal ulcer is a term given for Pseudomonas infection. Then we discussed the iris may be muddy brown in color, pupil is constricted, and intraocular pressure may be increased. So these are the clinical signs and symptoms. Then we discussed the complications, that is before perforation and after perforation. Before perforation, corneal scarring, then secondary glaucoma, toxic iridocyclitis, and and descematocele. Okay, remember descematocele. Then if the descematocele because of strain it perforates, it leads to perforation of the corneal ulcer, and this leads to prolapse of the iris, anterior dislocation of the lens, after anterior capsular cataract. Then it can lead to corneal fistula, which is important, purulent uveitis, endophthalmitis, panophthalmitis, and intraocular hemorrhage. Then we discuss the management, the important topical antibiotics used, and the treatment of the impending perforation. So this completes our